piece for it. So anyway.
Yeah, sure, no. Glad to help anytime.
Because in the original paper you said it was all adjudicated events.
So when you do the question and answer, Dr. Becker's going to be up front, Dr.
Okay.
O'Connor's going to be up, and then Elliot's going to be in the back. I've got to leave to go to a funeral, so they're
Great.
going to kind of help facilitate that for you.
Sorry about that.
Well, I understand.
Nothing hauls them in that, like biomarkers.
Good afternoon, everyone. It's a pleasure for me to introduce our speaker today, Dr. Michael Felker, who I've had the opportunity to work with and know for many years. Michael is from Arkansas, and that always stimulates a great deal of debate amongst his colleagues regarding politics, national politics. He had the opportunity to come to Duke as an undergrad, but chose to go to SMU on a scholarship. I think his dad said, if you take the scholarship, you'll get a car. If so, he made the wise choice, but came here for medical school and then internal medicine training at Johns Hopkins, where he served as ACR chief resident, which is really a faculty position at Hopkins. Came here as a fellow and worked in the heart failure group. Advanced heart failure training, has been on faculty now for over 10 years? Is it 10? Almost a decade, yeah. And recently got tenure as associate professor. He's published over 120 papers. He has currently 2 R01s. He's PI of the NHLBI Heart Failure Network. He's PI of the Guided study and runs a number of phase 2 studies across the country. It's really been great to see Mike's career flourish here in this setting, and it's great for me to hand over more and more work to Mike, so it allows me to do different things, like make schedules for faculty members.
Yeah.
So Mike's going to talk about the Guided trial. It's a really exciting trial. It's been one of Mike's passions, of biomarker-guided therapy in heart failure, and we look forward to your comments.
Great. Thanks, Chris. Is this on? Yeah, 10 years does sound like a long time, actually. So I'm going to talk about really the concept of biomarker-guided therapy for heart failure in general, and then specifically the guided study, which is a study that we've just launched here in the last, we just enrolled our first patient this month, being coordinated here through DCRI. So the usual extensive disclosures. So we're going to talk a lot about biomarkers, so it's good to start with people don't know what a biomarker is. So really a biomarker is just anything you can measure that you could use to help you take care of a patient. Usually when we talk about biomarkers, we're talking about blood tests, but it doesn't have to be a blood test, really. An EKG, your heart rate, anything could be a biomarker. And the biomarker we're going to talk about today is really a class of biomarkers called the natriuretic peptides, but I'm just going to use BNP sort of as shorthand, although it's really a family of molecules. So BNP is really a critical part of cardiovascular physiology. You can think of it as sort of the body's counter-regulatory hormone for all the bad things that happen to you when you have heart failure. So when you have heart failure, there's a lot of vasoconstriction, and BNP balances that with vasodilation. There's a lot of neurohormonal activation in heart failure, which is bad for you chronically, and BNP tends to counterbalance that. BNP has a lot of favorable effects on the kidney, and it also has direct effects on the heart. It's antifibrotic and anti-remodeling. And those of you familiar with the ASCEND trial, really the ASCEND trial was the idea of using BNP as a drug, giving recombinant BNP as a therapy for heart failure. But what we're talking about today is just measuring the BNP that your body actually makes and circulates as an important hormone in heart failure. And this is a little bit like troponin T and troponin I. There's basically two things you can measure in the blood that reflect the biologic activity of BNP. There's the actual BNP itself. So BNP is secreted from the myocyte as this big 108 amino acid inactive peptide that's cleaved into its active 32 amino acid ring. This is what actually has the physiologic effects. And its N-terminal fragment, which circulates, has a longer half-life, but is not biologically active. And there are blood tests available for this, and there are blood tests available for this. And they basically reflect the same general physiologic processes, but they have different sort of normal values. If you practice at Duke Hospital, most hospitals, just like with troponin, you have one or the other. We have NT-proBNP at Duke, and NT-proBNP is the biomarker we're using in the guided trial. So what does BNP reflect? So BNP reflects ventricular wall stress, or what we might think of as preload. And so, it is correlated somewhat with ejection fraction and some other measures like end-diastolic pressure, but this is really a remarkably tight biologic relationship. So you don't see too many things in biology that have an R-squared of 0.9. And so this is end-diastolic wall stress, or what we think of as preload, and BNP. So it's a very strong measure of the stress the ventricle is in right before contraction. And because of that, when you look at it in patients, what you see is that it generally, although not precisely, reflects filling pressure. So these are invasively measured wedge pressures, and these are BNP values, and a patient's getting diuresed, and you can see as their filling pressures fall, their BNP falls. And that's led to its use as a diagnostic test. So patients come into the hospital and they're short of breath, and the physician wants to know, are they short of breath because of heart failure or because of something else? And BNP was initially developed as a blood test based on this sort of classic study from Alan Mizell 10 years ago now for making the diagnosis of heart failure in patients who come to the emergency room who are short of breath. And conveniently, the best cutoff is 100, which is an easy number to remember. And so this is actually still the one class 1 indication for using a blood test in heart failure, measuring BNP in patients who come to the emergency room out of breath. Now, we also know that BNP is extremely, and I'll just use BNP as a generic term to include BNP and NT-proBNP, extremely powerful prognostic marker in basically almost any cardiovascular disease, but especially in heart failure. So whether it's all-cause mortality or heart failure hospitalization or cardiovascular hospitalizations, and whether you use BNP or NT-proBNP, you continue to see this extremely strong relationship with outcome, and this really persists despite adjustment for basically anything. If you look at most data sets and you say, what's the strongest prognostic marker in a chronic heart failure population, BNP is almost always first or one of the top couple. And this is also true in acute heart failure. So this is data from Jim Januzzi, patients coming into the hospital with heart failure, BNPs above and below the median, or NT-pro BNPs in this case. And you can see in this study, at least if you had heart failure and you had an NT-pro BNP below the median, you had a 0% event rate out past a year, whereas you had about a 30% event rate if you had a higher NT-pro BNP. So very strong prognostic marker, probably the strongest prognostic marker in heart failure. So the question is, how can we use this? If you read the literature, you would think that measuring prognosis was the single most important thing you could do, because the literature is just full of papers talking about prognosis, and researchers especially get excited about estimating prognosis because it's an easy thing to publish, right? You can measure something, you can look at the outcomes, you can see what the association is. But for individual patients, actually, it's not always so exciting to just know that the doctor has a good sense of that you're going to do badly. The question is, of course, what can you do about it? So that leads to what I'm really going to talk about the rest of the time is how can we use a biomarker like BNP or NT-proBNP to actually help us do a better job taking care of our patients. Well, we know from, and this is just a representative study, but there's many similar ones that that as BNP levels change over time, that those changes are reflected in clinical outcomes. So this is just data from big chronic heart failure study, Valheft. If your BNP started low and stayed low, you had a very low mortality. If it started low, so this is very good BNP down around 50, but rose over time, your mortality was higher. If it stayed high all the time, your mortality was quite bad, as you might think, but really want to focus on this. So if it started high and went low, you actually had outcomes not too dissimilar from staying low all the time. So this idea that it may be not where you start, but where you end up. And that's reflected in the fact that most of the therapies that we know are good for you if you have heart failure lower your BNP levels. So there's really two pieces of information. So one, if you can get at least from an observational standpoint, if there are decreases in BNP levels over time, that's associated with more favorable outcomes. And then the proven therapies that we use and try to encourage people to use also decrease the nitrate peptide level. So maybe we should think about titrating our treatments to try to achieve a specific BNP target, which is really the idea of biomarker-guided therapy. So chronic heart failure is very unusual for chronic diseases because if you look at the guidelines, what the guidelines say is you should up-titrate the therapy, so that's beta blockers, ACE inhibitors primarily, to the maximally tolerated dose or the dose targeted from the clinical trial. So that's not a very unusual thing. We don't say in hypertension you should up-titrate the blood pressure medications to the maximally tolerated dose. And an alternative hypothesis would be this idea of what you might think of as a personalized medicine approach. Can you titrate chronic heart failure therapy to something you can measure based on the personalized physiologic response of the patient? Or put in other ways, does every patient who has heart failure need to be on exactly the same doses of exactly the same medications? Well, it just makes sense that there's a lot of biologic variability, and of course they probably don't. Now, this seems like something of a strange idea, but actually this is how we treat every other chronic disease. So basically every chronic disease that we can treat successfully, and here are just some examples. So we'll take diabetes. So what we do to treat diabetes is we have an idea of amount of glycemic control that we think is associated with improved outcomes, and we have a marker that measures that, and we have a set of tools, and we titrate those drugs to try to get this in the right range and keep it there, and we know that that's associated with improved outcomes down the road. Same thing for blood pressure, same thing for LDL, anticoagulation, chronic viral diseases. Really the one prominent chronic disease where we don't kind of have this paradigm is heart failure. So this has now been tested in about 11, what you might think of as phase 2 size studies, trials of somewhere between, I think this one had 69 patients to a few hundred patients over the last 13 years now. And this was the first publication, Richard Troughton from New Zealand, to study in the Lancet. If you can get a randomized trial of 69 patients studied, published in the Lancet, then you have a novel idea probably. So anyway, this was a very small pilot trial, randomized patients to a strategy of titrating the therapy to try to minimize their NT-proBNP levels or just usual care. And even in this very small study, reached nominal statistical significance of improved outcomes with a biomarker guided approach. And I'll just show you a couple of representative examples. This is another study, a French study, STARS BNP. These are all specialty heart failure clinics, so at baseline, evidence-based medication use was quite good. But again, improved outcomes if you're randomized to the BNP guided therapy versus usual care. Importantly, in this trial, it wasn't just diuretics. So one of the things that a lot of clinicians say, well, if the natriuretic peptide levels are high, you should give more diuretics. But really, I think that's kind of a flawed approach, because all of these medications, diuretics, ACE inhibitors, beta blockers, mineralocorticoid antagonists, they all improve BNP levels. And the trials where this has worked, there's really been an emphasis on up-titrating all sort of evidence-based strategies, not just diuretics. And you can see in terms of this is total number of treatment modifications, that's true across all the classes. Now, a common concern or question is this just really disease management? So you're seeing these people more, maybe you're making all these measurements, and is it just better sort of heart failure care, and it doesn't really have anything to do, the BNP measurement sort of an epiphenomenon. So this is a 3-arm study from Austria, really trying to look at that. So patients randomized to usual care, what they called managed care, which was really what we'd call sort of disease management in a heart failure clinic, or a biomarker guided approach. And again, at least in this small study, less than 300 patients, sort of an incremental benefit on outcomes. And if you look at the proportion of patients who got what you might think of as sort of best possible therapy, you can see it's highest in those in the biomarker guided arm. And then finally, the last study I talked about is PROTECT. This was just published now a couple years ago. Single center study from Mass General. They were very interested in cumulative events as opposed to sort of time to first event, so total cardiovascular events over follow-up. Again, highly significant improvement for NT-proBNP relative to standard of care. And one of the interesting findings, they had an echo substudy in that trial, was that it wasn't just that this was better fluid management. If you look at changes in remodeling, you actually could see that there was, at least in this small study, improvement in remodeling looking at echo indices in those patients randomized to biomarker-guided therapy versus usual care. And there's been a couple of meta-analyses. This is one we did. There's been, this was 2009. There's been several other published studies since then, but the general results haven't changed. Now, if you look at these, you can have, if you're an optimist, you could say, wow, in this meta-analysis, there's about a 30% risk reduction for all-cause mortality, which is, in well-treated heart failure patients, is really a substantial improvement. If you're a pessimist, you say, well, this is just sort of regression to the mean. The bigger study you do, the closer and closer this gets to 1. And these are just some sort of enthusiast outlier trials, and this probably doesn't work. So that's equipoise. So I only talked about a few of these trials. There's basically been 4 that were nominally positive. There's 2 that have had strong trends, but were not nominally positive. And there's 3 that were completely neutral, actually a 4th one now. So if you look, and as I said, the biggest of these trials is about 400 patients. The smallest is 69 patients. Total around 2,000 patients randomized. If you look at what the guidelines say, I think the guidelines very appropriately still are quite cautious about this concept and basically say it's not well established. So class 2B indication level of evidence, a C, and that's not going to change when the new guidelines come out later on this year. So really, when you think about this concept, there's sort of 2 hypotheses that are both there, but they're different. So one is sort of a biologic hypothesis. So we talked about the relationship between LV wall stress and BNP levels. So we know that excessive LV wall stress is a major physiologic driver of ventricular remodeling, which is what drives heart failure progression, which is what drives people with heart failure to do worse. So a biologic hypothesis would be that if you could titrate your heart failure therapy in such a way that you minimized and then maintained LV wall stress at a low, what I'll call, quote, safe level, and kept that there over time, that would mitigate LV remodeling and slow heart failure progression and get improved outcomes. There's also what you might think of as a process of care hypothesis, because a lot of this is just about using the medicines we already know we're supposed to use in a more effective way. So that would be that you would suggest that by providing this sort of quantitative target, as has been shown in almost all the other trials, you can improve the use and intensification of evidence-based therapy compared to standard care and therefore improve outcomes. So really this lumps a lot of buzzwords from the current literature under one kind of general concept, and I'll just touch base on all of these. So personalized medicine, as we all know, is the idea of not just one-size-fits-all treatment, but giving the right treatment to the right person based on what we know about their biology. So this is really a great example, because right now chronic heart failure therapy in patients with systolic dysfunction is definitely one-size-fits-all. Here's the drugs, titrate them all to these doses, or until the patient says, I can't stand it anymore. So this is really an example of a personalized medicine as opposed to a one-size-fits-all approach. It's also really a classic comparative effectiveness trial, because we're not talking about testing new agents. We're just talking about how can we take the agents that we already have and try to use them in a more effective way to improve outcomes. So. And then finally, as people are aware, we're in this incredible epidemic of heart failure hospitalization that's become a huge public health problem. So if you're in Medicare and you get hospitalized for heart failure, there's a 25% chance you'll be rehospitalized in the next 30 days. And as Dr. O'Connor knows, hospitals are now across the United States are extremely focused on this, because CMS has said we're going to cut payment. We're going to cut your Medicare payments if you have unacceptably high rehospitalization rates. So there's huge focus on this as a public health problem, and it's extraordinarily expensive. So it's about $21 billion a year. So most of the heart failure costs in the United States are actually driven by these recurrent hospitalizations. And if we look at what's been proven to work, actually what it is just like we were talking about in biomarker guided therapy. These are just the different quality measures. The only two that have been actually definitively have strong evidence to show that they improve outcomes are actually increased use of ARB and increased use of beta blockers. So the same sort of medical therapies we're talking about trying to improve use. And as in so many other diseases, we see this risk treatment mismatch. So the highest risk patients shown here in the green are the ones who get treated the least with all these agents. And the lowest risk patients shown here in the blue are the ones who get treated the most. So physicians tend to undertreat high-risk people. I think that's a fairly common effect, certainly in cardiovascular disease. So really putting all these concepts together, this idea of personalized medicine, comparative effectiveness, these known gaps in care, and the heart failure readmission epidemic, and you put these all together, and what you get is Guided. So Guided is a NIH-funded randomized trial. We just enrolled our first patient right after the new year, coordinated here at DCRI, really trying to test these approaches that I've been talking about in a more robust fashion. So I'll quickly run through the sort of rationale for Guided. Really Guided is trying to determine the efficacy and safety of this strategy of a biomarker-guided therapy approach or strategy, minimizing NT-proBNP levels compared with usual care on what we have sort of the classic heart failure trial. Keep doing that. Clinical outcome of cardiovascular death or first heart failure hospitalization in high-risk patients. And we'll have the usual collection of secondary outcomes. We're very interested in cumulative morbidity, so not just the first hospitalization, but recurrent hospitalizations. If people were here for Stuart Pocock's DCRI Research Conference, he spent a lot of time talking about this issue. There's a lot of interesting new statistical, or maybe not new, but new to clinicians, statistical approaches to looking at these, which we're going to deploy and guide it. So multi-center, prospective, randomized, parallel control group clinical trial, unblinded, because this is a strategy that's not, certainly couldn't be double-blinded, could be single-blinded theoretically, although after a lot of discussion, this is an unblinded trial, and we can go into the reasons for that. 40 sites, US and Canada, reasonably long-term follow-up out to 24 months for most patients, 1,100 subjects. So this is the general design of GUIDED. I'll talk about the patient population a little more in just a second, but really targeting high-risk heart failure patients. So hospitalized for heart failure, identified and randomized at the time of discharge from a heart failure hospitalization. So what we know is the highest risk period is the first 6 to 12 months after you're hospitalized. Low EF and high NT-proBNP in the hospital. So if you're going to guide, you need something to something to guide. So people who've these are all so 3 strong risk factors basically: the fact that they got hospitalized in the first place, systolic dysfunction, and elevated NT-proBNP. So randomized at discharge or within 2 weeks. Usual care, biomarker guided therapy, targeting an NT-proBNP level of less than 1,000, and we could talk if you want about how we chose that. Standard every 3-month follow-up, which is pretty standard follow-up for high-risk heart failure patients, and then the usual endpoint. So I kind of touched on this. So we're targeting people with low ejection fraction who are in the hospital and a high NT-proBNP. Now, there's a lot of interest in what we call heart failure with preserved ejection fraction or HFpEF as a group of patients that needs better therapies. The problem with targeting that sort of population is we don't actually have any treatments to adjust that we know work. So we're really focusing on where the evidence is, which is in the low EF population. We know this hospitalization is a very strong marker for future risk. As I've mentioned already, this prevention of rehospitalization is a big public health focus. There's some nice logistic aspects of randomizing patients in the hospital for an outpatient study, basically. So I think this is a good opportunity to get sort of patient buy-in because they've just had an event, they've just been hospitalized, and now you're saying we have this potential strategy which might help prevent this from happening to you again. Finally, it's a very easy place to screen. So every day they're screening in the hospital, identifying patients who come in with heart failure. Then they have the whole length of their hospitalization to sort of talk to them about the study, have what I hope is a high-quality informed consent discussion, and then randomize at the time of hospital discharge. So the intervention, as I talked about, randomized to usual care, which is basically just follow the guidelines, or biomarker guided care, which is just treatments to try to achieve this target NT-proBNP level of less than 1,000. And the reason there are several reasons really to choose 1,000. One is it's a round number that's easy for me to remember. But additionally, if you look at the risk curve for NT-proBNP and prognosis, it's actually fairly flat until you get to about 900, 1,000, and then it inflects. So you want to really, if you believe that there's a quote safe level where LV wall stress is low and heart failure progression is going to be improved, the idea is to get down on that flat part of the curve, which is right about 1,000. So one question that always comes up is, we know from the guidelines that people should think human nature is, you can't really see this too well, but we tend to do better if we have a finish line or something that we're trying to work towards as opposed to just some nebulous run as far as you can and then stop. So one of the interesting challenges of implementation of this sort of protocol really has to do with adherence, and it's not patient adherence as much as investigator adherence. We often worry about adherence in our chronic clinical trials, but really just measuring something has no innate therapeutic value. So just knowing what your NT-proBNP level only makes any difference if the physician acts on it. So we actually have a protocol adherence committee who are getting not quite real-time, but almost real-time reports on failure to act on out-of-range levels, and there's a feedback mechanism to try to improve investigator performance with following the protocol. Now really where the rubber meets the road in the intervention is not just making the measurement, but making the measurement and then doing something about it. So the question is, what should investigators do to try to get the NT-proBNP level in the right way? And there's several sort of extremes. One is, that's just too tempting to push. One is the sort of cookbook approach where you just say, if you have an NT-proBNP level out of range, you should do this. And then another is kind of the other extreme, which you might call dealer's choice. So you just tell doctors, just do whatever you think is the right thing. And we've kind of taken a middle ground between these 2. So these are basically all the things that have been shown to decrease your NT-proBNP value in patients with heart failure. And most of them are essentially guidelines-based, especially up here on the top. And so this is sort of a suggested menu of choices for the investigator, and they can use their clinical judgment to deploy these in whatever order and whatever way, and they can do more than one at once to try to achieve a therapeutic target. So we talked about endpoints a little bit already, but we have sort of a classic chronic heart failure endpoint, time to cardiovascular death or first heart failure hospitalization. We're also very interested in this idea of cumulative morbidity. We have a robust equal core with a separate R1 led by Denmark and the equal group here. So we're going to have a lot of interesting data on safety, on resource utilization, cost, and health-related quality of life, and a few interesting things I've talked Kevin Anstrom into doing in terms of exploratory analyses. So if you look at our statistical power, I think we're well powered at 1,100 patients. We have about a 90% power for about a 20% treatment effect. And these are fairly conservative estimates of event rates based on the Everest study. I suspect we're going to have at least marginally and possibly significantly higher risk population than those studies. So one of the things to think about is whether to do an adjusted or unadjusted analysis of the primary endpoint. And this is the O'Connor graph. So this is HF action. So I think it said that you were going to do both, right? Was what it said in the protocol. So they got stuck here with a p-value of 0.13 in their unadjusted primary analysis. And when they adjusted, it dropped down to 0.03, so they had this kind of awkward result. So we're going to go for the smiley face, and we're going to have a primary adjusted analysis based on 4 characteristics where we think the data's missingness is going to be very low and that have been shown to be associated with outcomes. So this is the usual sort of organization. So it's 3 NIH grants. We also have been fortunate to have a fairly large investment from industry. Roche Diagnostics, which is the company that makes NT-proBNP, the blood test, is going to support an echo core lab and a biorepository, which I think is going to be a critical piece of this. So there's this really opportunity, I think, because this is we're going to have a very carefully phenotyped group of heart failure patients and a very unusual intervention. And it's not just a single drug. We're going to be collecting imaging data with the echo sub-study. We're going to have DNA, and we're going to have an extremely large biobank, which is going to be at Kannapolis. So at the end of the day, we're going to have really, I think, an exciting platform for discovery and science of heart failure, regardless of the outcomes of the trial. So this is the executive committee, which is many of the names that people are familiar with. And the most important slide is the people who are actually make it happen, and especially Gayle Painter, who's been an awesome project leader. This has really been a long thing. I think we started the initial discussions about doing this in 2007 or 8 maybe, and then 2 rounds with the NIH in a very difficult an era of difficult fiscal constraints. So we've been, it's really a tribute to a lot of people that this has come to fruition and started enrollment this month. So the final thing I always say is that because biomarkers are quantitative, because it's something you can measure, there's this tendency, I think, for human nature, for physicians to focus extensively or even exclusively on the value because it's something that comes on a printed piece of paper. It seems to have a lot of gravitas to it. But all blood tests have to be used in the context of a clinical judgment, so they augment but don't replace what we know already. And I was trying to make sure that I left time for questions. I might have left too much, but anyway, thanks. Happy to.
Thanks, Mike. That was superb, and there's never too much time for questions and comments. So I'm sure Dr. O'Connor would like to respond to you about his choice of adjusted versus non-adjusted.
It's always adjusted in retrospect.
Yeah.
Mike, great overview. One of the things that's emerging in the literature is this whole non-responder to suppression of the biomarkers. In clinical practice, we'll see these heart failure patients that just never move their end-terminal proBNP or BNP down, even though you're making adjustments. And the question is, could we harm patients by pushing things too high, too far, in the attempt to just suppress a number?
Yeah. No, it's a great question, and as you know, there's been a lot of discussion about this issue with the FDA and different IRBs. Maybe surprisingly, if you actually look at the data that's out there, so we've had about 2,000 patients randomized in various studies, there's actually not very much evidence of harm. Actually, the things that we could imagine happening, like hypotension, renal failure, hyperkalemia, so those are three big ones, bradycardia, I guess. Those SAE rates don't tend to be any different mostly than placebo. It is an interesting thing when you talk about safety, because on the one hand we're saying, well, couldn't this be dangerous? On the other hand, really what we're saying is give the proven medicines in the best, most aggressive way possible, which it's a little bit ironic sometimes that then we have to have a discussion about why we don't think that's unsafe to do, and really that's what we all know we're supposed to be doing anyway. But we're going to obviously be, this will be the most robust safety evaluation as well, but at least the studies that have been published so far I think are pretty reassuring in that light. There are definitely a cohort of patients, as you said, that their levels don't change very much, and we know that's no matter what you do, and that's obviously a poor prognostic sign. When you talk about where you're going to set the target for this sort of strategy, you could make you might say make an easy target where most people can get there, or you can make an unreachable target where a lot of patients don't get there. And if you look at the studies where it's worked, it's actually the studies that have set a very challenging target where it's tended, so people continue to push, those are the ones where the efficacy has tended to be high. So in PROTECT, for example, which is probably the strongest signal in terms of efficacy, only about a third of patients actually reach the target. So it's not that you anticipate that everybody's going to get there, but it's basically holding the sort of carrot out so far in front that you continue to push people to be more and more aggressive. Eric, I think, has the mic.
I'll go to you next.
Plus, we work for him.
Yeah. So I'm actually worried about the other extreme to a large extent. This is really challenging, as you laid out, the degree to which you have a completely unblinded study, you have investigators on one side knowing what they're trying to do and treating both sides of the equation, with a company supporting one half of it. It's a company supporting some of this effort. The point being here is, and then you've, at least as I understand, you've even upped the odds more by having a committee watching over the BNP side. Is committee both sides?
Yeah. Well, so the committee watches both sides. There's the usual care side is just is guideline. So there's not a.
But that's my point. The point is you're going to be ultra aggressive, both by the marker as well as by the protocol, as well as by the committee monitoring them, to push up medicines on one side. And on the other side, you're allowing usual care.
Yeah.
The potential for the difference here just being the degree to which people are aggressive without, if I give you fake numbers, just said really be aggressive on one side versus be sloppy, you'd find out that lo and behold, aggressive probably beats sloppy.
Yeah, no, so this is so there's a lot of different, that's a great question, there's a lot of different stuff there. So the adherence committee part, basically what they get is feedback on out of range values where there was no changes were made. And if sites where they're doing that over and over again, they don't say, go back to, this is if you're familiar with the Champion trial and this whole controversy, they don't say, go back to Mrs. Jones and make sure you up her beta blocker because we noticed you didn't do that. They say the strategy we're testing is reacting to values over 1,000 by intensifying therapy. So you need to make sure you're doing that when you have out of range values. Because if you If you don't do anything, if you just make the measurement, obviously there's no difference. You're just doing the same thing in both groups.
But I guess on the other side, that you could have done the same logic and said, if the patient didn't complain of, or you denote hypotension,
Right.
change in renal function, or symptom complaints that are associated with the drug,
Yeah.
up.
That's
And
what
if
the
you don't-
guidelines say.
But if you don't up, we're going to monitor you and ding you each time you didn't document why you didn't increase the medicine.
Yeah, so the guidelines say to do exactly what you said. As long as the patient is tolerating therapy, go up. But the data show that that almost never happens in clinical practice.
But that's what I'm saying. In this trial, you could make it happen. You
Is
could.
the trial reminding people to do proper care, or is it
Yeah, so there's
care
there's the adherence committee is following levels of evidence-based care in both arms, regardless of. But
Are you making each investigator, each visit, justify why they did not titrate
yeah,
up?
and the CRF, the way it plays out in the CRF is your value was 1,500, whatever it was. What change did you make? And one of the choices is didn't make any changes, and then the next thing that pops up is why. And there's a variety of reasons. You could say patient didn't tolerate it, patient refused. I just didn't think it was the right thing to do based on whatever. So yeah, I mean, this is obviously one of the things that comes up a lot as well. All you guys are doing is telling people to doing a blood test and then telling people to do what they should be doing anyway. And if that's true, then you don't need the blood test, but it doesn't, at least the data that's out there, it doesn't seem to be true. Every trial, even the one that was single-blinded, have shown that there's a lot greater intensification in the biomarker guided. It really gets back to this, a couple of analogies. One is I know I should get up early and go running, but I set an alarm clock to make sure that I do. And you could say, well, you just need an alarm clock. You just do the right thing anyway. But it's nothing wrong with using an inexpensive technology that reminds you to do the right thing. So I think, like all these strategy trials, it's easy to say, well, you should just be doing that anyway, but the issues are people aren't. And so can you use an inexpensive, $26 blood test to make them do better?
Perfect setup for the second thing is if you combine my question and Chris's and say that this is going to be in the hands of heart failure experts who are given a value, and some of them are good enough clinicians to realize that even though I wasn't able to get this patient to budge, I'm not going to push on this at a certain point. Conversely, on the other side, how generalizable are these results if you handed it to your average clinician in practice, they order these tests, will you get the same result?
See, so it's a great question, and we always worry about this in any strategy. I see it the opposite. So my personal view is that if you tell a experienced heart failure clinician, titrate these therapies as much as you can, balance them all, just the highest dose the patient can tolerate, that's what the guidelines say, that's actually a very challenging thing to do. That would be like telling up to insulin until the patient just barely doesn't have hypoglycemia. For your average non-heart failure expert, it's a lot easier to say, get the hemoglobin A1C below 7 and keep it there. And this is exactly the same way that your average primary care physician treats high blood pressure, cholesterol, diabetes, all the chronic diseases they deal with. They don't have to use kind of nuanced clinical judgment. They just say, this is a safe level of this biomarker, try to get to a safe level and maintain it. And that actually strikes me as easier to implement than the way the guidelines are now. So I don't know. We've tried consciously to have a variety. We actually are using ducks quite a bit in guided. We've tried consciously to not just be focused in sort of expert tertiary heart failure clinics in terms of sites, and we have a good mix. So we'll see at the end how that mix plays out.
So Mike, great talk. So I'm thinking about Eric's and Chris's comment as well too, and not knowing anything about heart failure myself, but
I don't know anything about gout, so we're
so we're even there.
Yeah.
And then, knowing that you spent part of the day yesterday with us talking about intensive hemodynamic study opportunities in the DCRU, I wonder if this is an opportunity to to use the DCRU as a tool in the context of this trial to sort out what's going on with the patients who don't drop their BNP despite intensive therapy compared to those who do. and actually sort out what's happening with the hemodynamics of this group.
Yeah, no, I think that's a great idea. I mean, they're definitely, when we see this clinically, they're sometimes it's obvious why, that you can't get it down. It's just that they're super duper sick. I mean, so sometimes it's not mysterious. Although you definitely do see people who seem to, a reasonably common scenario is you see people who get hospitalized for heart failure and they seem to respond. They seem to have gotten better, but their natriuretic peptide levels haven't changed very much. And we know, at least observationally, that those people have an extraordinarily high risk of coming back. So clearly, in that sort of scenario, the marker is telling you something that maybe you're not necessarily picking up at the bedside clinically, because even though these patients seem to be doing okay, and it's actually a testable hypothesis, and this relates back to the rehospitalization issue, whether we should use BNP as a target on the inpatient side and say when you get hospitalized for heart failure, you should be treated until your BNP gets down, drops a certain amount, or gets down below a certain threshold. And there's been a lot of talk about that sort of study design, although it's got a lot of operational challenges because you end up keeping people in the hospital extra days for the purposes of a research study, which then no one is happy to pay for. So yeah, I think it's great. I mean, DCRU, this up yesterday, I think, as I was telling you earlier, is I think a huge opportunity for a huge unmet need in heart failure research, because there's tons of kind of the drug development hat. There's tons of interest with sponsors and in drug development of understanding hemodynamics earlier in the process, and it's a really challenging. Because of Chris's escape trial, nobody does pulmonary artery catheters anymore, so it's a very challenging thing to do now on the clinical side.
Yeah, Mike, I could see some use of, if there's a difference between the two groups, but I mean, usual care doesn't preclude the use of BNP, so I could see people managing patients in usual care, because sometimes multiple practitioners can be involved, so BNPs would be available.
Yeah, so there's always this risk of sort of, you might think of that as kind of crossover or bleed over.
Yeah.
And the guidelines are actually, don't recommend that there's sort of a systematic use of natriuretic peptides, but definitely there'll be some what I'd call sporadic measurement of natriuretic peptides in the control group, and that's the real world, and that's a real world control group. So I don't think you can, or it's not even desirable to prevent that. But what will be different is sort of a systematic approach over time, trying to maintain a particular target versus sort of, I guess sporadic is a good word, utilization. Yeah.
Mike, that was a really nice description of the study. I'm curious about a general question about this type of study design where you're bridging between inpatient care and the outpatient care.
Yeah.
And I just wondered how you're planning to handle a situation where the physician caring for the person in the hospital is completely disconnected from the person that would be caring for them in the outpatient situation. Certainly, I don't know how many of your 40 hospitals might have hospitalists, and how are you going to get that level of adherence in the outpatient side if it's not connected?
Yeah, so the inpatient side you can really think of as just the sort of patient identification and screening thing. Really the whole trial takes place on the outpatient. You basically get enrolled as you discharge, as you walk out the door, or you can even be enrolled as an outpatient within 2 weeks. So, I think most places that are sites are part of some sort of integrated system, like where there's the same group of physicians taking care of people in the hospital and out. That problem, of course, is always true anytime you have transitions of care in outpatient studies. Patients get hospitalized, and patients. So, for example, patient is in a Duke chronic study, they get hospitalized for heart failure in Lumberton or at Moses Cone or wherever. So there's always those issues of sort of, which is part of our lack of integrated sort of health system across a region. So we're not the Mayo Clinic, but I think communication at the sites, I guess, is always the key aspect.
But is the site the outpatient clinic at the institution where they're hospitalized?
I guess I wouldn't think of it as being either or. They're together.
very quick question about the test itself. What do you know about interlaboratory variation or a test-to-test variation?
Yeah, so it's actually a very well-established clinical test, and now the platform that has been FDA approved for 14 years, I guess, and is out there in every. It basically has sort of standard clinical chemistry level precision. We're also at Kannapolis. We're going to actually also measure all the samples centrally at the end, so they're all run on one machine, and that'll include actually samples from the control. So the control group is going to have samples collected, but they're not going to be that information is not going to be fed back to the investigator. So at the end, we'll have core lab values on patients in both groups, all run on the same machine.
First, to congratulate you and your group on another practical question that clinicians would benefit from knowing the answer to. So I think the group has really done a nice job with having those projects funded, including through the NIH. John mentioned the DCRU, so I'll ask you the question. Are you doing a biomarker collection in your biomarker trial?
Yeah, so we have, we're collecting the blood for the NT-Pro, of course, but we're also storing plasma samples in Kannapolis serially. One of the things that happens a lot when we do these biomarker studies and heart failure studies is we get a baseline and then maybe one follow-up. But it's a chronic disease and with a lot of changes over time, so it's going to be storing every 3 months for the duration of the trial. So we're going to have, certainly we're going to have the biggest heart failure biorepository that I've been associated with at the end of the study. So it'll be a exciting, I hope, platform for, regardless of the results.
Mike, that was a great talk. I should probably know the answer to this, but what was the rationale? What was the rationale behind not blinding the patients to their BNP levels, and what are the pros and cons of doing that? Have previous studies used that approach before?
Yeah, so this is obviously something we went several rounds with the NIH and other peer reviewers about, you can even blind the physician, sort of. What you can do is have some sort of third-party physician in the loop where they don't know anything about the patient, but they just know the value. And the problem with that is that it creates kind of this, it doesn't reflect anything like real-world practice. You created this the trial sort of distorts the reality. You can definitely blind the patient, although even that has a little bit of complexity. There's at least some thought in the literature in this area is actually quite mixed that that there's a value to the patient in terms of their health behaviors in knowing what their target is and knowing what their value is. So if you say your LDL is 220, maybe you shouldn't get the pepperoni pizza. So that's the rationale, although that was a highly debated topic, and not everybody necessarily sees eye to eye. So and of course it also reflects real world, right? So whatever benefits it might have in the real world, patients are going to have access to that information, and that's increasingly true now. And you think about Health Portal, and all people are all looking at their labs and calling you to say that I noticed my chloride was low. Jet.
Hey, Mike. So we talked a lot about intensification of therapy. What are we capturing? I should probably know that.
Yeah, so it's a great. So one of the real challenges, and sort of, and Lauren's right there next to you. So one of the real challenges is in crafting the CRF was to capture all these changes in therapy in a way that was sort of that you could get your arms around, which is not something we usually try to do in this way, and not just the changes, but the rationale behind the changes. So not just what did you do, but why did you do it? So that's actually going to be incredibly interesting data to look at. So yeah, at each of these 3-month visits, there's whatever the doctor decides that they think needs to be done. This is true in the usual care and the biomarker guided arm. But there's also, then the next question is, whatever changes you make, why did you make them? And we'll have that serially over time. So in terms of sort of physician behavior, that's going to be with the caveat that it's always distorted by participation in the study, but that'll be very interesting to look at.
Well, if there are no further questions, Mike, thanks
Great.
so much, and
Thank you.
best of luck with your trial.